Uh, Nita, Sanjay, for inviting me for this and giving me a topic of my immense interest is the cognitive dysfunctions in diabetes. In fact, this has been our main area of studies. Last time I was given a topic by Bansi Sabu on 4 Ds of diabetes: depression, dementia, delirium and denial, and leading to diabulimia. And based on that, I realized that there are many issues that we don't pay much attention. Particularly clinicians, they look at the sugar; cardiologists, they look at the various aspects of the end-stage problems of diabetes. Now, I am unfortunately in charge of 3 hospitals in Bombay which deal with all the problems of diabetes, that is Raheja Hospital, all the problems leading to cardiac problem, that is Asian Heart Institute, and Asian Cancer Institute, which is going to be #1 killer in this country sooner or later if you don't pay attention to diseases like obesity, diet, and most important, various aspects which are not studied. Diabetes and mental health. Back in 17th century, diabetes caused long sorrow and other depressions. Long sorrow and depressions is a feature of diabetes, was realized as early as 17th century. Diabetes and mental health, the interface of diabetes and psychiatry has been fascinated both endocrinologists and mental health professionals. Why? Because both of them make money by not telling the patient, look here, you are bloody idiot, or you are depressed, or you are psycho. They keep on changing sugar, they keep on changing other factors. But this interference is very important. It's a very common. This may occur with one another. One may worsen the other. Please realize that the depressed diabetic is difficult to manage many ways. Psychological stress may follow screening of diabetes, as well as when the diabetes is first identified. Diabetes and psychiatric disorders share a bi-directional association, both influencing each other. This is very important. Now, type 2 diabetes is most common form. Only 15% cases attributed to type 1 diabetic. Can you just open this and give to it? Approximately a third of people with diabetes have a psychological and social problem that interferes with their ability to manage the diabetes. Remember that it's a very important topic. We don't pay much attention in clinician and endocrinologist clinic. We don't pay attention to this. Unfortunately, many times we face it that after some time, why this fellow's blood sugar is still 300? Why is he still not losing weight on his abdomen? What is the problem? So you realize that this guy is depressed. He's not able to come to terms with his illness. Psychological factors, acceptance of diagnosis. First of all, people don't accept. आम्हाला नाहीच आहे diabetes. हे काहीतरी तुमची लॅब चुकीची आहे. Denial, uncertainty. Denial and uncertainty created by media. Fear of hypoglycemia. Fear of complication. And adherence. One of the greatest fear is when the associations meet. All associations meet. माझ्या छातीत गोळा येतो. Because we don't know all the years what we are telling our patients, we have to tell them, no, Baba, the definitions are changed, the criteria is revised. There is something known as HbA1c kg paradox. Now what is this? You bring down the HbA1c to normal, but the kg body weight increases. Now kg body weight is a bigger risk factor than HbA1c. And today we do with the CGMS, time in range. More importance to time in range. So you just see how many confusing sciences are building up tension in the mind of a diabetologist who cares for his patient, cares for his community. But what happens to the patient and his family? Patterns of co-occurrence of diabetes and psychiatric disorder First two can present independent candidates with no apparent direct connection. Second, the course of diabetes can be complicated. Third, the certain psychiatric disorders like depression and schizophrenia act as a significant independent risk factors for control of diabetes. Now you remember, when a patient is labeled psycho, schizophrenic, or some beautiful names, it's very simple to call somebody as he's an idiot or येडेजाव आहे, हा idiot आहे, अक्कल नाही, म्हातारचाळ लागलं, खुळचट, त्याला गोंडस नाव दिले. गोंडस नाव काय? अल्झायमर्स डिसीज. The patient also feels extremely respectable. आपला काही फार मोठा जर्मन रोग झालेला आहे. This is wrong. What we are trying to create, we are creating psychos after normal people. The normal people who live normally, if they don't have these inputs coming from various associations. Think about it seriously. Implications of co-occurrence of diabetes and psychiatric disorder, which impairs the quality of life, increase cost of the care. Most important, the cost of the care goes up. Poor treatment adherence, poor glycemic control, increased risk for diabetes-related complications, premature mortality, early deaths, increased emergency room visits due to diabetic ketoacidosis, higher cost of the treatment, higher frequency of hospitalization, and higher rate of abstinence. Dandiya. People are chucked out. Depressed diabetic patients, we have to write a certificate that he is not depressed. Although his salary is cut down by 50%, he is not depressed. We have to tell lie. The bugger is depressed. I can't declare him depressed. Depression is like a bad word. Diagnosis psychiatric disorders among patients with diabetes. Biggest challenge in the management of psychiatric disorders. Up to 45% cases of mental disorders have severe psychological distress. Physicians should be aware of the possible comorbid psychiatric disorders likely to be associated with diabetes. And this is what happens with the multifactorial disease like diabetes has a multifactorial reason for depression. The depression could be a feature of dementia, which could be atherosclerotic dementia. It may not be Alzheimer's disease. I tell, shouting to my all medical students, look here, Alzheimer's disease is known as pre-senile dementia. It is not a senile dementia. 80-year-old man, you can't call him dementic because of Alzheimer's disease. A 45-year-old man, and the cognitive function in such persons are grossly affected. Mechanisms that may link diabetes and dementia, multiple. You'll study that in a short. There are diabetes and Alzheimer's pathology is almost 3. So you realize that type 3 diabetes, what is type 3 diabetes? Type 3 diabetes, Alzheimer's disease. There is an insulin signaling system in brain. Up till now, people thought that brain organ, the neurons are independent of action of insulin. Both low insulin and extra insulin. Low sugar, high sugar. These chemical things bring about changes in neurons and cause early dementia. The 5 Ds of diabetes, depression, one of the most serious mental is a major depressive disorders affect adults above 18-year-old. The comorbid depression and diabetes is very difficult to treat. I have already talked to that. Managing depression and diabetes can be successfully treated with person with diabetes. A treatment of psychotherapy with antidepressant medications have shown moderate improvement, not too much, but the side effects of antidepressive drugs are too many. What is the dementia and diabetes link? Mechanism of association is not known. High blood sugar or insulin can harm the brain in several ways. The brain depends on many different chemicals which may be unbalanced by too much of insulins. Some of these changes may trigger dementia. High blood sugar causes inflammation. This may cause the damage to the brain cells and help dementia to develop. Reducing risk of dementia in diabetes. Remember, what is good for your heart? Obviously, common sense tells you it is good for your entire body and brain. It cannot say it is only good for your heart. So, what is good for your heart is good for your brain. Living a healthy lifestyle and promote, which improves the cardiovascular health, will improve the cardiovascular, is a health of brain as well. Eat a healthy diet rich in vitamin D, folate, B6 and B12 vitamins. Exercise regularly. There is no substitute to exercise. Delirium in diabetes could be manifestation of hypoglycemic episodes or diabetic ketoacidosis. Patient diabetics suffering from comorbid psychiatric disorders are more likely to explain hypoglycemic delirium. Delirium is associated with various adverse outcomes, including increased hospital stay, increased cognitive and functional deterioration, morbidity, and increased mortality. Features of delirium, either hypoactive or hyperactive. Hyperactive means clinic मध्ये बसल्या बसल्या इकडे तिकडे हे बघ ते हे करते. Hypoactive, depressed, like this, like Parkinson. They come like this, as if the whole world is coming to a collapse. While hyperactive, difficult to manage. In front of you, you handled at least or broken 2 of your pieces on your table. So where hyperactive, depressive, psychotic comes, I clean my table completely. The other clinical features of delirium include perceptual disturbance such as hallucinations, sleepwalk cycle disturbance and thought disturbances. Very, very common. Hallucinations could be many. Dr. पैसे दिले होते ना तुम्हाला मी. These are deadly hallucination. When patient has not paid, he feels that he has already paid your fees. Management of delirium in diabetes, mainstay of the treatment is correction of underlying cause and supportive care. Patient low-dose dopaminergic antagonist, also known as typical antipsychotic, could be used to control of behavioral disturbances. Denial. This is the worst problem. मला डायबिटीसच नाही. तुम्हाला काय कळत नाही डॉक्टर. Goes on too long, interferes with your self-care, and consequently can be very dangerous. After you first diagnosed with diabetes, it's normal at the first to minimize. And how they present? Spotting denial. Denial has a few catchphrases. If you hear yourself linking as saying them, you're avoiding them. One bite won't matter. अरे एवढं खाल्लं काय होत नाही. This sore will heal by itself. I've seen. My father also had it. My mother also had it. This sore has been there. It's a non-healing bloody ulcer. It can lead to cancer. How can you tell him this, that? I will go to doctor later. आज नको. आज गुढीपाडवा आहे. आज कोणी डॉक्टरचं तोंड बघायचं. I don't have time to do it. I don't have time to do it. This is a fantastic excuse. बाकी सगळं करायला टाइम आहे. My diabetes isn't that serious. I tell you, I only have to take a pill and not shots. People who take oral hypoglycemic agents and don't take insulin, they have feeling that they have some kind of a less serious disease. And our doctors are responsible for it. Some doctors give 5 drugs, 6 drugs. I don't know why they don't start insulin early. But people who don't take insulin, they feel they don't have a serious disease. Signs of diabulimia, खादारपणा, हवरटपणा, regular changes in weight, awkwardness or questions about diabetes control or injections, avoiding clinic appointments. आमच्याकडे पाऊस पडतोय. बॉम्बेमध्ये दिस कॅन गो ऑन. दादरला पाऊस नसतो पण परेडला असतो. आमच्याकडे पाणी तुंबलंय. And there is a dry air. Having high HbA1c, skipping injection which causes hypoglycemia, low sodium and low potassium can also cause problem. Increased appetite, especially in sugary foods. How does diabulimia affect body? Blood sugar levels can surge and can occur greater risk of ketoacidosis, swings of sugar. If a blood sugar is 200 for a long time, it's not a big deal, but a blood sugar 60 in the morning, 300 in the afternoon, 350 at night, fluctuations of sugars are more dangerous. And that's one cause of eating. Many doctors, like spouses coming and telling, साहेब तुमच्याकडे असे काय ओळख आहे की आमच्या रेफ्रिजरेटरला लॉक करून मिळेल, हे रात्री उठून खातात. Common complaint. Both type 1 and type 2 diabetes have a reduced performance on numerous cognitive functions. Implications of, sorry, I think we had to go up. Most common cognitive defect in type 1 diabetes is slowing of information processing speed. Now what is this? Children are taught some lesson. They have to process it to go into their brain and become a protein. The memory is in a form of protein. Like I don't want to say we Brahmins, but at the age of 10, we are all Dashagranthi Brahman. 10 books learned by heart without knowing a single word about it. Huh? But learning by heart has a better recall in the later ages. Children who are taught, their processing speed is very slow. यांना ना इतर मुलांपेक्षा कळायला वेळ लागतो जास्त. कळायला वेळ लागतो दोन गोष्टी, कारण पोरगा फळ्यावरती बघत नाही, बाईच्या ब्लाऊजकडे बघतो. Attention diverted span can change the processing speed. Worsening psychomotor efficacy, deficit in motor speed. Now whatever is processed to come out of his mouth, you ask him a question, he has understood it. He's got the knowledge. But to answer it in a proper sentence, he fumbles. Reduce vocabulary, reduce constructions of the sentence is the first sign. Now, poor vocabulary and general intelligence, poor attention, deficit in somatosensory examination, poor motor strength and memory. Better glycemic control improves cognitive performance of type 1, improves seen in motor speed, verbal, IQ scores, and most important, the performance in the school. If the blood sugars are well controlled, type 1 diabetics do well in the exam. Cognitive functions are negatively affected. Type 2 diabetes, memory short-term and delayed, psychomotor speed and comprehension, complex motor functions. Now, complex motor function means it could be just buttoning the shirt and wearing a trouser will be a simple act, but the person will fumble for the pant and not button the shirt. It is not a complex act. Forget the complex art of driving, and they are not, qualified to do that. Fluency in speech and attention. The loss of speech or ability to talk fluently. I think ability to talk fluently, if Nita keeps on calling me frequently, my fluency will increase. It is the number of times you use your brain, vocabulary, talking. Therefore, to remember one thing, I always tell my friends, you want to learn something, try to teach. Teaching is the best form of learning, and that was happens. HbA1 more than 7, fourfold increase in developing cognitive impairment. IGT without diabetes is also a risk factor in cognitive dysfunction. This is a pathophysiology of cognitive dysfunction in diabetes. You can study this slide in detail. That gives the sum total of exactly what I talked all this time. No copyright, you can take photograph also. Now, modalities for reassessment of a cognitive function. New cognitive testing, evoked response potential, EEG MRI, and select PET scanning. Role of insulin resistance and amyloid. Now, this historical brain thought to be an insulin independent, no more thought to be. However, the PET scanning showed significant increase in brain glucose metabolism in a setting of hyperinsulinemia in humans, which may play a role in Alzheimer's disease. So this is possibly my last slide. And thanks.
Thank you, Dr. Alka. Come, I'll just make a comment. Because we are running short of time, I will